continuing on the same theme, and good morning to all of you. So this is my situation where I actually have a flight to catch in 6 hours, and I'm not really wanting to do anything at this point. But my neurointerventionist, who's a good friend of mine, and also my landlord, says, "No, nobody else wants to do this, and you have to come and help me out because you are the one who keeps on saying that we will bail you out if anything goes wrong." Okay. So I really didn't wish to, do this. Very difficult. I am already in an aloha mode, and then this is the situation. A lady who came in, we have a very good stroke center, and we get a lot of neuro cases, coming to us, and we have 3 neuro interventionists. So this was the situation. Somebody comes in with collapse, has aneurysmal coiled up, has residual aneurysms, which needs to be coiled later on. But the axis site, slowly starts to show, and that foot turns cold. And at this point, I am called in because 2 of my partners have turned down the patient. So, it's colleague asking for help. And I look at this, and I was like, okay, it doesn't look that dramatic. This is something which we have tackled and all. So I go in there, and then I call him. I start out and say, "Hey, this is what I have," and of course, he is my friend and landlord both, and he says, "Do whatever because the family is very upset. I'm likely to be sued." I said, "Okay, that's a good thing." And then I asked him, "What can I do for anticoagulation?" And he basically says nothing because it's a very high risk to bleed. And this is the cartoon which expresses my feeling. At this point, I really didn't wish to be there, and then I am entrusted with this. And yes, I have been in practice for a while, but I have never encountered such a situation where I had no option to use therapeutic anticoagulation, because if I can't use a therapeutic anticoagulation, how do I do this? So I thought about it, that okay, I have to minimize the hardware as smallest fidelity as possible. So I didn't even take a destination sheet or a crossover sheet. I just crossed in there with a 014, used aspiration catheter, and did multiple aspiration thrombectomy. At least at this point, we have a flow, and then did a very soft balloon angioplasty. And then I am left with this. Of course, this vessel is traumatized. If I leave it this way, it might stay open, but then when I go down, there's nothing going down to the foot. So knowing what we know now, I have to do something about it. So, it's a friend. I do take the chance, put 2 014 wires out. I don't have a sheet. I have nothing to have a lot of support, but still I managed to slowly get my balloons down, do PTAs. And at this point, I am feeling a little good. That, what? The likelihood of this leg being amputated is much less now. But then the intrapopliteal, still I don't think I have, I don't think I have as good flow as I would have liked. But I am quite happy. I need to go. I need to catch a flight. I deserve vacation as well. And then, as I am pulling up, I see this. Okay, so I cannot escape this out. Sorry. Then I do a soft ballooning there. And guess what happens next? I lose profunda. Things are getting one worse from here. And then I treat the profunda, and then another nightmare. As you guys can see, there is a clear extravasation at the arteriotomy site. This is after a soft balloon angioplasty. And at this point, I am feeling worse, because what do I do now? I can't anticoagulate. I can't, I will do, so I did internal and external balloon, internal balloon tamponade and manual compression. And I guess I was really lucky. It really worked out. So this is a situation which I had never encountered. And keeping aside the fact that, what I had to do in that situation, but what I managed to accomplish in this case was by using the lowest fidelity tools, despite not being able to use therapeutic anticoagulation, I was able to save the leg and save my friend from whatever could have come up through his way. And to my surprise, while I was at the airport in Phoenix waiting for the flight to LA, to Maui, my fellow calls and says the foot looks warm and all that, and I just said to him, dude, you made my vacation. So what I learned was that yes, there are situations where we are going to be in a no-win situation. But if we think about it, if we try to do whatever little we can, it doesn't have to be perfect. But many a times, not being perfect also helps us to achieve something which can be life-saving or limb-saving. And that's why I use that quote, Dr. Das, that sometimes we just have to keep going. And this was one of those cases.
Perfect, thank you.
Are there any comments from the panel?
It's just amazing to have seen a case without heparin that actually, you were able to salvage the leg. I think that's amazing. I personally never been in this situation, so it's remarkable.
Let me ask the surgeon on the panel, how easy is it to open that common femoral artery and fix it without anticoagulation just to get some flow?
So we see this actually in trauma cases, in cases with vascular trauma, and they have other, they have concurrent head trauma or other abdominal trauma. And in theory, you can give them, and we've done this where you just give localized heparin. So you just give heparin down the leg. And if this is truly just an access site complication, it's probably a very small hole, or it's probably some subintimal, some plaque or something that got lifted up. So the repair, although it won't be perfect, can be pretty fast in terms of if it was a perclose, you cut the stitch out, right? And then it's like one stitch to close a 5 French hole in the artery. So you can get, technically you could do this under local if you really had to, and instill local heparin, which if I was asked about this case, you always run into the trouble with trying to do thrombectomy without heparin. That's always a problem. But
And that's a very good point and learning point for me. The city where I am in, we don't have vascular surgeon, the whole city.
Interesting. What thrombectomy device did you use?
So I actually used the priority 1 because I was using the all 014 wires. I had no choice but to use our coronary tools.
So let me ask another question because we have 2 more minutes, and please, if somebody in the audience has any. What about when you passed a wire there, forget about trying to do atherectomy and distal embolization, just put a very, very short self-expanding stent in that area and just I know it's not ideal, I know it's the common femoral artery, but this is an older lady who's had a bleed in her head and a stroke. She's not going to be running marathons, but just to prevent distal embolization, just open flow. Is that a crazy idea, or is that kind of okay to do?
I think if you have a very sick patient and you need to fix the problem, I don't see any problem with it, because it is ultimately, it's a life versus limb problem, right? So you could, and you put a covered stent in there, it can come out. Actually, a Viabon or an ICAS can,
and
they
not
can
even
come
that,
out.
just a regular self-expanding stent. But I guess the challenge is always you cannot anticoagulate, you don't give Plavix, you cannot give aspirin.
Yeah, but we'll see this in subclavian or axillary trauma. If they are bleeding and it's very hard to get access there, sometimes your best thing is to just put a Viabon there so that they're not going to exsanguinate, and then deal with it later.
But one thing the child said that my biggest worry was that if I take any high fidelity tools, even a destination sheet say into the iliacs, and I can't anticoagulate, what if I propagate the clot further? What if I make things worse?
In my experience, the sheath is not the problem.
Yeah.
I take sheath sometimes down to the popliteal to get selective good images on diagnostic without everything. I think more of a problem is leaving the stent behind or something like that.
Right.
Well, anyway, thank you very much for another good case.
Thank you.
Next is refractory vascular wall healing after paclitaxel-coated nitinol stent implantation in the fempop artery, a high-resolution angioscopic success.